Need the darkroom development that we had the old films techniques. So it's quite improvement. The X-rays immediately you can, once you take an image, it appears on your computer screen. This is what you get for an X-ray. You see the renal areas are here. The urinary tract includes the ureters and the urinary bladder lies here. So these are soft tissues. You are not able to see them unless you give contrast. So for contrast, when you inject contrast, it is called as IVP or intravenous urography. Okay? But before we do that, we have to make sure that the renal function tests are normal. You know why?
Because the contrast
The iodine has a side effect. It can damage the kidneys if the function of the kidneys is not normal, because the contrast would accumulate in the body and it would damage the nephrons. So we need to have the urea creatinine levels normal. Recently, a lot of urologists and nephrologists are not doing IVU because it's a sort of invasive procedure. What they're asking is a plain CT scan because it gives almost the same information that you get through the IVP. And obviously CT scan is much quicker, much faster, and the results are much more, you get more information rather than IVP. So, but if you are to do IVP, you still need to have 4 to 6 hours fasting because the injection that you give, there are chances of vomiting, nausea associated with that, and the patient, if he's lying, he can aspirate at the same time. So this is what you get. IVU, once you inject the contrast, it outlines the collecting system, but you cannot see the kidney as such. Okay, like the CT gives you not only the collecting system, it also shows you the kidney outline. Similarly here, you can see that the bladder is there, but you cannot tell whether the wall of the bladder is normal or not. All you can see is the intraluminal part, which is outlined by the contrast. So this is what you get. These are the normal callaceal system, upper, middle, lower pole calyces. This is the ureter and this is the urinary bladder. So this is what you get with IVU. As I said, renal impairment, you cannot do this with renal impairment and the patients who are sensitive to contrast. The ones who are sensitive to iodine. Because obviously iodine has its own reactions. These days we are using non-ionic contrast. Does anyone know what is non-ionic? That's a name, but what is non-ionic? Why do we use non-ionic? Does anyone know? Non-ionic is actually low osmolar contrast. Low osmolar. Low osmolar means that the iodine is bound with an organic atom, and that the osmolality itself becomes less. Previously we were using high osmolar contrast, so the reactions were more. These days we are using non-ionic contrast, which is low osmolality, so the reactions in the blood once you inject this are less, with very few, hardly there is, now if you inject say 1,000 cases, hardly there is 1 or 2 reactions, and even these reactions are very minute ones, like the patient has some sort of breathing problem, or the patient has itching, or the patient has sort of nauseating feeling. That's it. Usually these are overcome once there are medicines which can control this. So it's quite safe now. Ultrasound, you again know, it's sound waves that we are using to get images, and obviously the soft tissues allow the sound waves to pass through. The hard things like bones, stones reflect the sound, and that is that produces the image which we require. It's a non-invasive procedure, good resolution, widely available. Ultrasound is quite cheap and easily available. Now what we can do is, with ultrasound we can look for stones, any parenchymal changes, for hydronephrosis, for bladder mass, renal mass. So a lot of things can be picked up simply by doing an ultrasound as an initial investigation. This is the kidney that you see. This outer black area is the cortex. The medulla is slightly white. Why is it white? Anyone knows?
blood vessels on urine?
Because it has the
calyces. Fat inside, sinus fat. The fat is echogenic on ultrasound. So cortex, the medullary region has more fat inside. That is why it is more echogenic or bright. By the way, the stones also appear bright, but they have acoustic shadowing behind them. I'll show you how it looks like. CT is a good investigation now, as I've told you, it replaces the IVP now. Why? Because it's not that we are not concerned about the cost effectiveness in the sense we want the patient to be discharged immediately. If we know the diagnosis, if there's no stone, discharge the patient home. So we can also give contrast like we do in IVP. It's very fast, so it's useful in trauma cases. Stone, tumor, infection, congenital anomaly. So angiography. Angiography is a good way because if you suspect renal artery stenosis, you can sort of evaluate this after injecting contrast. So additional information can give you, especially in cases of trauma, it is very useful because you need a result immediately.
No.
This is what you get, the kidney areas. By the way, the kidneys are retroperitoneal structures. So they lie in the retroperitoneal regions. These are the psoas muscles. This is the vertebra. Okay. So plain CT scan is something like this. There is no contrast given. Why do we do plain? We want to see the stones because the stones appear bright. Okay. So, but remember, the drawback is more radiation compared to X-rays. MRI is safe. It's expensive, takes more time compared to CT scan, but has better soft tissue characterization. For tumor evaluation, it is much better. But for stones, is it good or is it bad?
But
Why? The stones appear black. So unless you are familiar with them, so CT scan detects more stones or you can measure them more easily compared to MR, because MR, it will appear, the stones appear black. So black is not that easily picked up.
What is the best modality for stone? The CT or
CT. On MR, every sequence it will appear black. Like the bones in MR. Bones on MR, the cortex, if you look at the cortex of any bone, it is black in every sequence. So it doesn't really help. Yes?
some stones are radiolucent.
I'm coming to that.
Yeah.
Okay, so we are unable to image the calcium, which is the stones. Majority of the stones are made of calcium. Nuclear medicine is another investigation which is used for functional tests. What is functional test? Working of the kidneys. We can identify how much the kidney is functioning. Like if you have both kidneys, if you do urea creatinine, it will just tell you the general information of your functioning kidneys. But if you want to evaluate right from the or compare it to the left, the nuclear medicine would give you separate sort of curves. It will tell you how much right is functioning, how much left is functioning. This is important for the clinician to know how much function the kidney is there. Like for example, if there is an obstruction which has resulted in old hydronephrosis, the kidney is non-functional now. The surgeon wants to know whether it is non-functional before he takes it out. Okay, so nuclear medicine is very important because it gives you the functional. You can compare both kidney functions at the same time in the same investigation. We use two types of nuclides, DMSA and DTPA. DMSA is metasuccinate acid. It's a sort of nuclide tracer that we inject. It's the same way you inject in the arm, in the vein, and it goes and collects, the tracer accumulates in the renal areas, in the cortex. So this is how it looks like. You see the small images, these are the tracer accumulation because this tracer accumulates in the nephrons there. So the DMSA is different from DTPA. It will give you whether the cortex is scarred or not, or whether there is damage to the cortex itself. In DMSA study, we are just trying to see the anatomical outline of the kidney, not the excretion. In DTPA, which is the other tracer that we use, we are trying to see how much the kidneys are excreting. Understand? Do you get my point?
Yes.
DMSA just tells you the anatomical detail, like the cortex, is it normal or is it abnormal? Whereas DTPA tells you the excretion of the contrast in the collecting system. So from the collecting system, you can tell whether there is hydronephrosis or there is no hydronephrosis. Whereas in DMSA, it just tells you whether the cortex is scarred, whether some tissue is abnormal in any part of the kidney.
So doctor, why is it the DMSA, if it's only anatomical, why is it considered as nuclear medicine?
in some cases where we suspect chronic infection resulting in kidney loss like scarring, we do DMSA. If we are concerned about the excretory function, whether it is hydronephrosis, whether the kidney is properly excreting contrast, then we do DTPA. Why? Because we get these curves. You see, the contrast that is injected or the nuclear material that is injected is excreted. If it is not excreted, the curves go up. So this tells you there is obstruction. So we can derive these curves from these images. From these images, these curves tell you. For example, this curve is going up. This means the tracer is accumulating in the kidney, not being excreted. Whereas this comes down means it is excreted in the urine. So this tells you the functional element. This is what I was saying. It can tell you the functional element. So you can compare the right from the left curve. We'll see about these in detail in the next sort of lecture, which is more practical. Now, the plane, what is the difference between this and this radiograph? Anyone?
This one is
He hasn't emptied the...
More fecal matter. The more fecal matter makes the outline of the kidneys difficult to visualize. Whereas in this case, the outline is easy to visualize. So this is more appropriate once you give injection of contrast. You will see the ureters and the kidney and the bladder. Whereas in that case, you will not be able to see because of the overlying fecal matter.
Do we give the patient something to...
Yes. So we prepare the patient by enema and Dulculex tablets, laxatives. So this is what you get once the preparation is fine. You will see the collecting system, the ureter and the bladder. And this is the same image if you do it on CT. Okay. So this is a 3D reconstruction of a CT. So you can see the same information now you can get from CT. So that is why a lot of people are now changing to CT urogram rather than just the IVU, which was the old method. Another example, advantage of CT is angiogram. You see the renal arteries. You can see the renal arteries. Do you know what is renal artery stenosis?
Yes.
It results in large kidney or a small kidney? Small kidney. Over a period of time, the blood is limited. The blood's flow to that part is compromised and the kidney becomes small in size with time. So renal artery stenosis can be picked up by doing CT angiogram. By the way, these are normal renal arteries. If you see narrowing here, then you will be able to tell the surgeon there is narrowing of the renal artery, put a stent inside or do a dilatation inside. This I have already shown you. This is how the ultrasound looks like. There, this is the specimen. Why it is white, I told you, there is fat there. Now, the ultrasound also helps you stage the kidney. Is it normal? Is it early disease? Is it mid disease? Or is it end stage? For example, this is how the normal looks like. Okay, this is the early part when the cortex is used. You compare the thickness and the echogenicity. As time passes, the cortex size reduces. So this means that the nephrons are losing their function. And this is hardly any cortex, paper thin cortex now. So this is end stage renal disease. This patient needs a transplant. Okay, so this is how it progresses. This is how the normal goes, then early or moderate disease, severe disease, and this is when it is end stage disease. Obviously the kidney has lost most of its function. We've talked about the kidneys as a retroperitoneal organ. You should know that it is surrounded by fat. What sort of fat is there?
Peri and para.
Perinephric. So there are some fascias which limit the perinephric fat, anterior one and the posterior one. Does anyone know what is it called? Gerota's fascia is the anterior one and the posterior one is Zuckerkern. If you don't remember the name, just remember these are, what are these?
Fascia.
These are simple perirenal fascias, anterior and posterior perirenal fascias. Okay, so you can see them here better, anterior and posterior. By the way, these perinephric spaces communicate. If you go down, they will communicate in the lower pelvis. So these are sort of limiting the disease process there. So this is nature's way of limiting the disease to the perinephric space. This is what I just said. Anterior component is the Gerota's fascia and the posterior component is the Zuckerkern fascia. These sort of encase the kidneys. There are few other contents that you should remember. Kidneys, adrenals, ureters, perinephric fat. These all form the perinephric space. Contents of the perinephric space. Now, these are all CT images at the same level, that means at the same time. But remember, this one is without contrast, this is in the early phase, this is slightly delayed, and this is quite delayed. You know the phases?
Facial contrast.
Plain.
Arterial.
This is called as
Arterial.
corticomedullary phase. Why? Because the cortex and medulla can be separated. The cortex is bright and the medulla doesn't have contrast, so they are sort of, there's a differentiation between the cortex and the medulla. So we call this as corticomedullary phase. If you look at this, there is contrast in the aorta. Here, you see contrast in the aorta and the IVC, and look at the kidney, it is all white now. So the contrast now has also gone into the medulla. So this is called as nephrographic phase of the CT scan. So this is nephrographic phase, usually it is 10 minutes, 5 to 10 minutes delayed, and this is quite delayed when the contrast is being excreted into the collecting system, the renal pelvis. So plain, corticomedullary, nephrographic, and the last excretory phase. So this is all different timings. The kidney is scanned at different timings depending what we need. It depends what we are looking for. Some tumors would take up contrast in the early phase. If we are looking for the function or the excretory function of the kidney, then we do an excretory phase to look for the ureters and the urinary bladder. Now let's see some examples. The same information you would also get with MR. This is CT, this is MR. So same, it's just the timing of the contrast. So the items which are commonly to be discussed, we'll discuss them in detail in next lecture, but just to show you simple examples. So, young patient with left flank pain, hematuria, no fever, WBC. History suggests stones. These not infection, the WBCs are normal. These are these stones, and because of these stones, you can look at the collecting system, how dilated they are in the IV. Okay? So multiple stones in the left kidney and the dilation of the collecting system. Again, stones in the urinary bladder. Okay? Look like eggs lying there. This is calcification of the urinary bladder wall. This is seen in schistosomiasis. What is schistosomiasis?
Schistosoma infection.
It's a parasitic infection. Okay, so it results in calcification of the urinary bladder wall. So these are different types of stone. Does anyone know which stones are not radiopaque?
The ammonium, magnesium.
Uric acid and little bit of cystine stone. Okay, so these two types of stones are sometimes not picked up on ultrasound, but CT, majority of them are picked up. Okay, so this is another example of a stone in the pelvis. You can see the dilatation of the collecting system. This is stone in the bladder. This is how you see them on ultrasound. I told you they look bright, and there's a shadow behind them. Again, a stone in the kidney, the same one. You see a shadow, black shadow behind the stone. This is how they appear on ultrasound. But you see, it is much nice and much easy to see them on CT scan. Now, this is a stone which has resulted in hydronephrosis, the enlargement of the kidney. Compare it with the other side. This is normal. The other side, everything is dilated. Why? Because this stone is not letting the contrast come down. Again, stones in the kidney. Another stone, these are plain films. So this is a Staghorn calculus. Staghorn means all stones are sort of united together, like the staghorn, the horn of this deer-like structure. So it's been named after this. So they look like all stones are connecting. So actually they're filling up the collecting system. Upper, middle and lower pole collecting system. So what does this do? If you don't get it out, obviously the kidney would over a period of time lose its function. So the function of the kidney would reduce. By the way, urea creatinine levels, would it be raised?
No,
Why? The urea creatinine levels would not be raised. There is another kidney to compensate for that. The nature has given you two kidneys. Even half of the kidney is functional, urea creatinine levels might not be raised. So this is why it is important to detect them earlier on. Unless if it goes into end stage renal failure, then obviously we can't do anything. Another example, of a woman with flank pain, fever, high WBC, looks infection. So history is quite